Good morning. Welcome to the Department of Medicine Ground Rounds. Remember that you have to call in to get credit for being here today. I think there's a number right in front of the podium. Where to call or how to do this is right here. Please don't forget that. So you have heard about the Nobel Prizes this week. And of course, the Nobel Prize for Medicine was Yoyu Tsu from China, William Campbell from Ireland, Satoshi Omura from Japan. They all worked separate and some together for the development of new therapies against parasitic agents. But today it's all about the kidney. Today it's all about the kidney. And I do not know what our speaker is going to say. However, I suspect this lecture will be very different if it wasn't for Rodney Porter, who was born on this day in 1917. And Rodney Porter was a British biochemist who shared the Nobel Prize in 1972 for his discovery of the chemical structure of antibodies. And Cesar Milstein was born on this day in 1927, who also won the Nobel Prize with George Kohler and Jern for his studies on the immune system and the discovery of the principle of the production of monoclonal antibodies. In fact, his group was the first to develop hybridomas, which are now used and allow us to develop monoclonal antibodies for therapeutic uses. And then in 1918, on this day, was the birth of Jens Skou, S-K-O-U, who was a Danish biophysicist, and he was awarded, with others, the Nobel Prize of Chemistry in 1997 for his discovery of nothing less than the sodium-potassium ATPase. Now, somehow, these must be related to the kidney. That's my best way of putting this together. But I think what you're going to hear today is much more exciting. And with this, I'll leave you with Eleanor Letter, the Chief of Nephrology and Hypertension.
I remain terrified that I'm going to fall one day when I'm walking up those stairs. So it's my pleasure to introduce today's speaker. I think all of you guys here know Dawn Castor very well. Dawn did her undergraduate work at Case Western Reserve and then came to the University of Louisville for medical school, stayed on for internal medicine residency, and we were fortunate enough to recruit her to our fellowship program. She distinguished herself during her training and became the chief medical resident here prior to becoming a renal fellow. She has initiated a research program in looking at immune-mediated causes of kidney disease, in particular glomerular disease, and is one of the major faculty who staff our glomerulonephritis clinic on Wednesday afternoons here. Her own research program is primarily aimed at looking at the antibodies that are present in the serum of patients with lupus and trying to figure out what their actual glomerular targets are. Today, however, she is going to talk about another glomerulopathy, membranous nephropathy, which she has also been studying in the lupus patients and in which our own program has had a major role in the discovery of the pathogenesis. Two articles in the New England Journal of Medicine have come from work done in our proteomics lab that is headed up by John Klein. And both of these papers were groundbreaking in identifying specific pathogenic targets of the cause of membranous nephropathy. So with that, I'll ask Dawn to come up and talk to us about this exciting subject.
Make sure it's on. Sorry, the light should be coming on. Okay, green light. Good morning, everyone, and thank you so much for that kind introduction. I'm excited to be giving my first Grand Rounds lecture as an attending here at University of Louisville. As you know, I've been here through almost all my training, and I'm a native Louisvillian. So I'm going to give the talk today on membranous nephropathy. I've titled this talk From Bench to Bedside and Back Again. It's a story that inspired me, and I hope it will inspire you. So the learning objectives for today are to provide an overview of the pathogenesis of membranous nephropathy. In doing that, I'm going to describe the discovery of the phospholipase A2 receptor, and yes, I know that's a mouthful. Through the rest of this talk, I'll be describing that as PLA2R. And if you walk away with nothing else, I hope you will be able to link PLA2R to membranous nephropathy by the end of this talk. So I'm going to describe the discovery of PLA2R as the predominant target antigen in membranous nephropathy. I'm going to be providing information regarding the application of PLA2R antibody testing in clinical practice, as it is a test that became FDA approved about a year ago and we are using. And I'm going to identify gaps in understanding other immune-mediated kidney disease and areas of future study. So as a clinician, I like to start out with a case. This is a case I had a couple years ago that the house staff might actually remember because they were involved. A 48-year-old Caucasian male with no significant past medical history presented to the hospital with anasarca. On exam, blood pressure is 125/70. He has 3+ pitting edema and body wall edema. Creatinine is normal, 0.9. Albumin is 1.8. Urinalysis shows 4+ protein. Complement levels are within normal limits. HIV, hepatitis panel are negative. SPEP is negative for monoclonal protein, and a 24-hour urine demonstrates 17 grams of protein. I think we would all agree this isn't one of these, maybe we should get a biopsy. We should definitely pursue a kidney biopsy for diagnosis in this patient. So he underwent a kidney biopsy, and I first show you a high-power view of the glomerulus here. In silver stain, we use Jones silver stain to highlight the basement membranes. In this case of early membranous, there isn't a lot of obvious change to the basement membrane. Looking up close, there are some holes, and we frequently look for spikes, which are a late finding. And these holes and spikes are indicative of areas where there are immune deposits, and the basement membrane is kind of forming around those deposits. And we thought he had immune deposits, and certainly on immunofluorescence. His IgG is very dominant with a 3+ IgG staining in a granular capillary loop pattern. You can see here. He also had a little 1+ C3, which I did not show. And then on electron microscopy, I always get a little disoriented when looking at electron microscopy. So I've shown here on the left a normal kidney, and just to get you oriented, this is what the podocyte should look like. This is the epithelial layer. Here's the basement membrane, and here's the endothelial layer. So that's what a very nice capillary loop should look like. And in this patient, if you're confused and trying to find the capillary loop, it's easy to find the red blood cell. So you know you're in a capillary loop. And here, you're not really seeing nice podocyte foot processes. And underneath here, there's a large amount of this deposit in the subepithelial space. So this is classic for membranous nephropathy. We know it's an immune-mediated disease characterized by immune complex formation in the subepithelial space, leading to podocyte foot process effacement and loss of the podocyte barrier, leading to massive proteinuria. So I will explain why this is important, but this case was one of the first cases where we had the ability to stain for PLA2R, and PLA2R, the target antigen in membranous nephropathy, in this patient was found in a similar granular capillary loop pattern, making it very likely that this patient had primary membranous nephropathy. So just to give you some background, primary membranous nephropathy is a leading cause of nephrotic syndrome in adults. The peak onset is in the 4th and 5th decade of life. The incident rate of end-stage renal disease in these patients is quite high if untreated. 14% at 5 years, 35% at 10 years, and 41% at 15 years. It is a slowly progressive disease. Even with treatment, about a third of these patients will have a progressive kidney disease and eventually end-stage renal disease due to lack of treatment response. It is a disease that is more predominant in male, 2 to 1 male to female predominance. It is more predominant in the Caucasian population. However, it is seen in all races and all ethnicities. And about 75% of membranous nephropathy is termed primary, or as many of you probably heard it previously described, idiopathic, and the remaining 25% is secondary. So while my talk isn't focused on secondary membranous nephropathy, I think we all should consider this anytime someone is diagnosed, since about a quarter of patients with membranous will have a secondary etiology. So the causes of secondary membranous include autoimmune diseases, classically systemic lupus. This is actually termed class 5 lupus nephritis or membranous lupus nephritis. Mixed connective tissue diseases, malignancy, especially the solid tumor malignancies, and the incidence of malignancy being associated with membranous nephropathy actually increase with age. So if you have a patient over 65, is a much higher incidence to be related to malignancy. Medications, NSAIDs, gold, penicillamine, even TNF inhibitors have recently been described as linked to this in multiple case reports. Infection, hepatitis B is a big infection associated with membranous, rarely hepatitis C. Syphilis as well. It's also seen in graft versus host disease in bone marrow transplant patients and in sarcoidosis. So pathogenesis. So this is a 50-year story in the making, and it's a fascinating story. Here is a picture. You know, you saw the electron microscopy. This is a pictorial version of the capillary loop, and you have the podocytes here making up the epithelial layer, and then the basement membrane, and then the endothelial cell. So membranous nephropathy is characterized by immune complex deposition in this subepithelial space. And there were kind of three main theories of how these immune complexes became deposited in this space. So the first theory that was proposed was that circulating immune complexes, you know, kind of in the bloodstream came across the endothelial layer and deposited somewhat passively into the subepithelial space. The more recent theory, and what I'm going to show is probably the etiology of the majority of primary membranous, is that circulating antibodies actually bind to a native podocyte antigen, leading to in situ immune complex deposition. And then finally, non-native antigens can get planted in the subepithelial space, followed by circulating antibodies to the antigen. So like many diseases, the pathogenesis was first studied in an animal model, and it was a rat model developed by Heyman and his colleagues in 1959. So they were able to produce nephrotic syndrome. This model is now termed the Heyman nephritis model, and it's still being used to study membranous nephropathy. A major discovery in the Heyman nephritis model was finding that, at least in the animal model, it was caused by in situ immune complex formation. So it was not circulating immune complexes depositing in the glomerulus, but a circulating antibody binding to a native glomerular antigen that caused disease. And that antigen was identified as GP330. In the late 1980s, GP330 is also termed megalin, and that is the main target antigen in the Hayman-nephritis animal model. So based on animal work, it's supported that human membranous nephropathy is secondary to circulating antibodies binding to a native podocyte antigen. This animal work also led to the discovery that local complement activation occurred when these anti-megalin antibodies bound to megalin on the surface of the podocyte, leading to the insertion of the membrane attack complex, basically the breakdown of the actin cytoskeleton, the breakdown of the slit diaphragm, and thus the development of proteinuria. However, while some humans might be rats, rats are not human. So as is a problem with a lot of animal work, there is a gap between the animal model and human disease, and megalin is not seen on human podocytes. So that led to two additional questions. Is human membranous nephropathy the result of in situ immune complex deposition like the animal model? That wasn't known until recently. And what are the target antigens in human disease? So the first report identifying in situ immune complex deposition as an etiology of human membranous nephropathy actually occurred as a case report. And I like to point out this case report because it really was a huge leap in our understanding of membranous nephropathy. It was in 2002. So for all those house staff that are like, oh, I don't know if I should write this case report up, it might not contribute much. This case report actually was published in the New England Journal. And it was a case of antenatal membranous glomerulonephritis due to anti-neutral endopeptidase antibodies. And what happened was healthy parents, the mother actually had neutral endopeptidase deficiency that did not cause any ill health, and developed antibodies during a prior miscarriage. And during the second pregnancy, these anti-neutral endopeptidase antibodies crossed the placenta and led to membranous nephropathy in the infant. So when the child was born, they had features of nephrotic syndrome with acute kidney injury, but over the first year of life, all of this resolved because those circulating antibodies were no longer there. So this case really suggested that human membranous nephropathy was caused by circulating antibodies leading to in situ immune complex deposition. However, this neutral endopeptidase was only the etiology in a few cases. So this was the first case. It was actually reported in a couple other cases. And this is just confocal microscopy, basically co-localizing the IgG with the neutral endopeptidase. And here in yellow is where you see the antibody and the antigen kind of overlapping in the kidney. And this was a biopsy from that patient. So 7 years later, we finally were, I say we, I wasn't part of this study, but some of my mentors were part of it. I'm very proud to say that Dr. David Powell, Dr. John Klein, and then a graduate student here at University of Louisville, Tim Cummins, were all part of this discovery. So 7 years later, it was identified that the M-type phospholipase A2 receptor, or PLA2R, was the predominant target antigen in idiopathic membranous nephropathy. So this is a huge discovery in nephrology. We went from a disease that was idiopathic to now calling it primary. Primary because we finally know what the etiology is. It was 50 years in the making, and it took a lot of work. But we now know that 70 to 80% of patients with what was previously called idiopathic membranous nephropathy have antibodies to this PLA2R protein. So how did they do it? They couldn't work with an animal model. So they actually took human tissue, human kidney tissue, and they isolated glomeruli, and they ran it on a Western blot, and they used human sera from patients with membranous nephropathy, and they looked at what it reacted to. So they were trying to find the target protein. So they found this 185 kilodalton band that was present in patients with membranous nephropathy, but was not present in patients with other kidney diseases such as focal sclerosis and diabetes. To further characterize this protein, they actually deglycosylated the protein, and they ran another immunoblot, and they found that the band shifted, suggesting it was a glycosylated protein, which is common in membrane proteins. And for each of these patients, it shifted in the same manner, suggesting that for all these patients, the protein target was the same. Further, they found that 70% of their cohort had this band at 185 kilodaltons. So what was this band, and how did they find out what it was? Well, that's where UofL comes into play. So our proteomic group basically takes the corresponding gel bands to that 185 kilodalton protein and sends it through this miraculous mass spec machine and comes out with a list of proteins. So there were 18 proteins in the original list, and PLA2R was further validated as the target protein. And if it weren't for the advances made in proteomics, this discovery probably would not have happened. So to validate PLA2R as a target protein, they took recombinant PLA2R and blotted that with the sera of patients with membranous, and it did indeed react. They also looked at biopsy tissue, and they found that in the patients with membranous nephropathy, the IgG and PLA2R co-localized in the kidney. Here's a close-up of that. Where a patient with secondary membranous nephropathy did not have this co-localization. Finally, the last step of validation included the elution of antibody from remnant biopsy samples of patients with membranous nephropathy, and they took that eluted antibody and they were able to demonstrate that it reacted to recombinant PLA2R. So we know from that study that PLA2R seems to be the target antigen in a large majority of patients with membranous nephropathy. So how do they stand up as biomarkers? How do antibodies to PLA2R stand up? So are they diagnostic? Do they correlate with response to treatment? And are they predictive of outcomes? And since 2009, there has been a huge amount of literature on this topic, including the original study by Beck and colleagues, as well as a number of other studies that were published since then. This meta-analysis demonstrates the sensitivity and specificity of PLA2R antibodies as a diagnostic test. So the sensitivity is fairly high, 78%. So specificity is much higher, 99%. So this test has good sensitivity and very good specificity in identifying patients with membranous nephropathy. Now, one caveat is that each of these studies use different diagnostic means to identify PLA2R. Some use Western blot, some use ELISA, some use an indirect immunofluorescent test. So there might be some variability in sensitivity among individual tests. This other study that looked at the response to treatment looked at PLA2R antibodies as patients were treated for membranous nephropathy. And this is just an example of 4 different patients and 4 different treatment patterns. So in patient A, you can see that the antibody goes down during treatment. And in patients that stay in remission, it stays away. In patient B, the antibody levels go down, but they didn't disappear completely. This bottom panel is just a longer exposure than the top panel. Patient C, the antibodies never went away. And this patient did not have a treatment response. And in patient D, the antibodies initially went away and then they came back. And when they came back, it corresponded to a relapse state. From that same study, they demonstrate that patients' antibodies might actually go down before the proteinuria goes down. So here in the gray squares is the decrease in PLA2R antibody in the serum. And here in the black diamonds is the decrease in proteinuria. And this is just the percent change from baseline. And in this case, you can see that the patient actually had an immunologic response prior to having an actual clinical response, but did have a clinical response that followed, suggesting that, you know, in these patients, a lot of times we worry about, is our therapy working? So we're looking at the clinical response, a reduction in proteinuria, to decide that. And based on this study, it suggests that, you know, if we see an immunologic response, that maybe we should stay the course and continue treating with what we originally started with, because a proteinuric response will follow. So it does seem correlative of a clinical response developing. And then if there is not a change in antibody level, there is not going to be a clinical response here. And then this demonstrates a patient that actually had a relapse. So they had an increase in proteinuria at the same time their antibody level was increasing. So it does look like we can use these levels to correlate to response to treatment. Finally, this study actually looked at the presence of PLA2R antibodies as predicting disease outcomes. So in membranous nephropathy, we decide on treatment based on the level of proteinuria. So in patients that are subnephrotic, they're considered to be very low risk of having progressive kidney disease, and we just monitor them. We don't treat them with immunosuppression. This study actually took a group of patients that were subnephrotic, and they separated them from those that were positive for the PLA2R antibody and those that were negative. And here's the cumulative risk of, or cumulative number of patients who maintain subnephrotic proteinuria. So basically, over the course of 1 year, if you had PLA2R antibody positivity at diagnosis, 80% went on to develop nephrotic proteinuria, suggesting that the presence of these antibodies at diagnosis is actually suggestive of them developing worse disease, and that maybe for this cohort of patients, we should follow them more closely in that first 12 months. So what are we doing in the clinic? So there are 2 tests that recently became FDA approved. So the discovery was in 2009, and in May of 2014, this became FDA approved as a clinical test. There's an indirect immunofluorescence test, which does not give you quantitative, it's just qualitative values, and the ELISA test, which gives you quantitative values, and this is the one we're currently using in the clinic. It's only available at 5 institutions. We're sending ours out to Cincinnati Children's. Hopefully, you know, this test has only been available for about a year, but hopefully there will be more labs performing this test as time goes on. And for those of you that were here at the beginning, when I talked about PLA2R staining in the kidney, you know, the patient actually had positive staining for PLA2R. It has been shown that patients have increased presence of this protein, and this is another way of diagnosing PLA2R mediated disease. And this study came out in 2011, identifying that a large majority of patients that were PLA2R serum reactive were also positive on biopsy staining. And we actually had the biopsy staining available, and we're using it in the clinic before we even had the serum antibody levels available. So I know in our clinical practice in 2013 was about the time when we started seeing PLA2R staining on biopsies. So a lot of times you'll hear us saying biopsy was positive for PLA2R, and then the serum was positive for PLA2R, and those together really support the diagnosis of membranous nephropathy. This study also suggested that there might be a cohort of patients, there were 10, that were positive in the biopsy, but were negative in the serum, suggesting that they also had PLA2R-mediated disease. Why the serum levels were negative is debated. You know, could they be undergoing a spontaneous remission, or is all that antibody kind of stuck in the kidney and not circulating, is the question. But at least this group felt like the biopsy might be a little more sensitive than the serum levels, and I like to use both. I say more data is good. So the biopsy has also been used to help determine secondary versus primary membranous. And this group, Nephropathy, looked at a large amount of of primary membranous patients and looked at those that stained PLA2R positive. And what they found was really interesting, kind of supporting the literature that says 70 to 80% of patients with primary membranous are PLA2R positive. They show this, 75% of their patients with quote-unquote idiopathic membranous nephropathy were positive. However, they also showed this interesting finding that cases that were secondary were also showing up PLA2R positive. So 3/4 of patients with sarcoidosis, 1/4 of patients with neoplasm, and a large majority, about 65% of patients with hepatitis C, secondary membranous nephropathy, which kind of begs the question, are these cases all secondary, or is a proportion of them actually two separate disease processes going on at the same time? And this really does change the way we treat patients. This is a test kind of demonstrating the same thing on the circulating antibody levels. This study looked at patients with primary versus secondary, and it does look like about 30% of their cohort of cancer-related membranous nephropathy actually were positive for serum PLA2R antibody levels, which also suggests that maybe in this portion of patients, they actually had two separate disease processes going on at the same time. It's still being debated. So that brings another case. So this is a case that might have previously been described as a secondary membranous. This is a patient that was also seen by the house staff here in the last few years. 32-year-old Hispanic male with a history of HIV, presented with acute pulmonary embolus. Creatinine was 0.9, albumin 1.9, and 24-hour urine showed 12.9 grams of protein. Hepatitis profile was negative. RPR was negative. And, you know, initially the patient was on anticoagulation, so the biopsy was delayed. He's also HIV positive. So for a period of time, you know, it was thought, oh, he probably has HIV-associated nephropathy. He did finally get the biopsy, especially when he had persistent proteinuria despite a negative viral load. So you should not see that with HIV-associated nephropathy. It usually improves when HIV is treated. So his biopsy showed a very similar finding to the initial one I showed. And he was also very strongly positive for PLA2R. And later we were able to test his serum, and he had circulating antibodies to PLA2R, suggesting that in this case, he had two separate diseases. And rather than, calling it secondary and not treating, he should probably be treated as a primary membranous nephropathy. I don't want to finish this talk without mentioning some other target antigens. So this was published last year, and I'd also like to point out that Dr. Mike Merchant and John Klein from our Louisville group were also part of this discovery. So what about the 20 to 30% that aren't PLA2R positive? They probably have other target antigens. And this thrombospondin type 1 domain containing 7A, that's a mouthful, was also found to be a target antigen in about 10% of the patients that were PLA2R negative. This is not available as a clinical test yet, but our friends up in Boston are willing to run samples if needed, if it's suspected. A few other antigens have also been identified. So aldose reductase, superoxide dismutase, and alpha enolase. And these antibodies were found to be in conjunction with PLA2R. So they weren't in PLA2R negative patients, but actually in PLA2R positive patients, suggesting that there might be some secondary antibody formation that occurs after the initial damage occurs. So in summary, after decades, literally decades, 50 years, a targeted proteomic approach led to the discovery of PLA2R as a predominant target antigen in primary membranous nephropathy. PLA2R antibody levels and PLA2R antibody staining in the kidney biopsy are useful for diagnosis. So checking circulating levels and then staining for the protein itself can be very helpful in establishing a diagnosis of primary membranous nephropathy. These antibody levels may be helpful in monitoring response to treatment and also may be predictive of disease outcomes. Do we think a similar approach can be used to identify targets in other immune-mediated kidney disease? Well, since my early career has counted on this, yes, I really do think that this approach can be used. And I just want to briefly talk about that. So my research is predominantly in lupus nephritis and in identifying target antigens in lupus nephritis. So lupus nephritis, like membranous, is characterized by immune complex deposition. Unlike membranous, the deposition is everywhere. So it can occur in the mesangial space, it can occur in the subendothelial space, which we typically associate with class 3 and class 4 proliferative lupus nephritis, and also in the subepithelial space, which is class 5 or membranous lupus nephritis. And Beck and his colleagues, when they were looking at PLA2R, they actually did test PLA2R in patients with membranous lupus, and they weren't PLA2R positive, suggesting that the immune complexes were formed with different target antigens. So it's controversial, and the composition of immune complexes in lupus is diverse and includes anti-nuclear antibodies, anti-double-stranded DNA, as well as other autoantibodies. And actually, some groups have eluted antibody from patients with lupus nephritis and found that anti-nuclear antibodies account for a very small percentage of the IgG in the kidney of these patients, suggesting that there are several other processes going on. So just like in membranous, the deposits can occur with circulating immune complex deposits, kind of passively getting trapped in the glomerulus. They can occur when circulating antibodies bind to native antigens in the kidney, and they can occur when circulating antibodies bind to planted antigens in the kidney. And our research here is focused on identifying native target antigens. in lupus nephritis. So we used an approach similar to Beck. I like to call this the Beck approach. So we start out with human kidney. You know, animal models have their issues. They can be wonderful, but we start with human kidney because the protein composition can be different. And we take that kidney and we isolate glomeruli. And we prepare glomerular extracts, separate protein by SDS page for use on Western blot, and then we blot with sera from patients with lupus nephritis. And unlike membranous, these patients react to multiple bands. So this is just an example of 3 patients, one lupus without nephritis, one with proliferative lupus nephritis, and one with membranous lupus nephritis. And you can see here in each of these patients there are several reactive bands. So we tried to, we looked at a number of individual patients and we tried to summarize their reactivity and get a pattern of reactivity to find out which bands to target. And we identified 2 areas of interest where patients without nephritis did not have a lot of reactivity, but patients with nephritis did. And this is just that area of interest in a number of patients. So these are the individual patients. This is patients without nephritis, so not a lot of reactivity in that area, and patients with proliferative nephritis and patients with membranous nephritis. And we took that band of interest and again sent that to the mass spectrometer, got a list of proteins, and this list is a list of membrane-associated proteins. And we identified 2 that were very interesting. They were involved in actin regulation, they'd been previously described in glomerulonephritis, and they were identified as slit diaphragm proteins. And in this, we went back and for further validation, did an ELISA looking at serum reactivity of annexin A2 on 10 individual patients and subjects. So we had 10 normal controls, 10 lupus without nephritis, 10 membranous lupus nephritis patients, so class 5, and 10 proliferative lupus nephritis. And we were able to identify increased reactivity to this protein, annexin A2, in the patients with class 3 and class 4 lupus nephritis, so with proliferative lupus, suggesting that annexin A2 might be a potential biomarker to identify patients with proliferative lupus and help separate them from patients with membranous and patients with lupus but no nephritis. So this work was recently published. The other protein of interest, mosin, we have not published that yet, but are working on it. It was presented last year at the American Society of Nephrology meeting, and we also showed increased reactivity to this protein in the proliferative group. And then further studies looking at this protein to see if it had increased expression demonstrated that there was increased glomerular expression in patients with proliferative lupus nephritis. This is immunohistochemistry. Mosin is actually a pretty abundant protein. It's an protein. And you can see that it's in the tubules here in a similar pattern in the normal control and the proliferative lupus nephritis sample, but in the glomerulus it has a very different pattern with enhanced staining, especially around the capillary loops in the proliferative group. So in conclusion, a targeted proteomic approach led to the identification of PLA2R as the predominant target antigen in membranous nephropathy. And if you get nothing else out of this talk, I really hope you're able to walk away and know that membranous nephropathy is no longer termed idiopathic. It is now primary because we know the target antigen in 70 to 80% of those cases, and that discovery happened here. So go UofL. Thanks to Dr. Klein and Dr. Powell and a wonderful graduate student, that discovery was made possible, the end of a 50-year search. PLA2R antibodies are actually currently being used as biomarkers to help diagnose and treat primary membranous nephropathy. So here in our glomerulonephritis clinic, we are using this test to identify patients that have primary membranous nephropathy and to follow them during treatment. I've been getting them, when I'm trying to make a decision about changing therapy. So, it is happening here in the clinic. We have a biomarker that is working. And a similar proteomic approach can be used to identify biomarkers in other immune-mediated kidney diseases, such as lupus nephritis. Now, I know my work is very early, and I'm early in my career, and I'm hopeful that it will be followed by more validation studies in a larger cohort. But I really think that we can use this approach in several immune-mediated kidney diseases, including lupus nephritis. I'd like to thank my colleagues at University of Louisville, especially those that have helped mentor me and work with me on my research. John Klein, Eric Cortes, a graduate student here that helped me with the ELISA data that was presented. Kenneth McLeish, Michael Merchant, and David Powell have all helped mentor me in my early academic career and hopefully will continue to mentor me. We have collaborators at University of Cincinnati that provided samples and also at Ohio State University, and this work was made possible from an NIH grant that Dr. McLeish and Dr. Powell are co-investigators on. Thank you very much. I'll take any questions.
Thank you, Dawn. Dr. Castro was a little anxious coming here, delivering her first round. On behalf of the audience, you did a terrific job.
Thank you.